Welcome to the Osteoarthritis Action Alliance Lunch and Learn for August 2015. My name is Kirsten Ambrose, and I appreciate all of you taking the time to join our webinar today. I'm pleased to introduce our presenter, Robert Sallis. Dr. Sallis is board certified in family medicine and holds a certificate of added qualifications in sports medicine. He is a family physician practicing at Kaiser Permanente Medical Center in Fontana, California, and serves as co-director of their sports medicine fellowship program. He is also the head team physician at Pomona College and chairs the Ironman Sports Medicine Conference in Kona, Hawaii. Dr. Sallis has chaired the healthcare sector of the U.S. Physical Activity Plan and is the physician spokesperson for the Everybody Walk campaign. He is also the past president of the American College of Sports Medicine and currently chairs Exercises Medicine, a joint initiative of the American College of Sports Medicine and the American Medical Association. Today, he will speak about exercises medicine, the importance of connecting fitness and healthcare. Welcome, Dr. Sallis.
Thank you, Kirsten. It's really a pleasure to be able to bring you this webinar on the health effects of exercise and the importance of trying to connect fitness with healthcare to try to improve health and prevent chronic disease. You know, it's a bit depressing to me as a family physician to realize what contributes to the overall health status of my patients. About 20% is your genetics, and if you're smart enough in the beginning to pick the correct set of parents, you give yourself a big leg up. About 20% is your environment. Obviously, if you live in an environment that exposes you to infectious diseases, to poor food and water sources, to toxins, obviously that can impact your health as well. Only about 10% though is access to medical care. And so with all of the pills and procedures we prescribe, my gosh, we're almost bankrupting the country with our healthcare costs. It only accounts about 10% of whether or not my patients are healthy. The other 50% is behavior. And when you distill it down, there are really three basic behaviors that most contribute to our overall health status. The first is how much you exercise. The second is whether or not you smoke. And third is the type of diet that you eat. Well, I think we've done a good job with smoking. It's hard to find anybody around the United States over about the age of 5 that doesn't know that smoking is harmful and hazardous to your health. We certainly have given the diet piece a try. It's hard to turn on the television or look at any media outlet without hearing how fat we have all become across the United States. And you know, we've officially seen to it that obesity is now a disease, and we've got all kinds of folks touting their latest diet books, but it's done almost nothing. In fact, this obesity problem has just gotten worse. And I think that focus so much on diet has come at the expense of exercise. We really talk very little about exercise, and I really think that's a mistake. And I think as a public health issue, focusing more on the exercise piece makes a lot of sense. And the reason for that is that we know that physical inactivity has an astonishing array of harmful health effects. We've got multiple studies to show us that exercise is a powerful tool both for the treatment and prevention of chronic diseases. For helping with the obesity problem, it certainly is helpful in losing some weight and certainly maintaining that weight loss. But more importantly, we know that exercise has a powerful effect on mitigating those harmful effects of obesity. And in fact, when you control for physical activity levels, obesity has very minimal impact on mortality rates. We also know that those who exercise live longer, and the rates of premature death are substantially lower. And in fact, we have seen from multiple studies that there's really a linear relationship between a person's physical activity habits and their health status. Those who enjoy an active and fit way of life live longer, healthier lives, while those who are sedentary and unfit very predictably begin to suffer prematurely from chronic disease and die at a younger age. And it doesn't matter what population you look at, this association between an unfit way of life and premature disease exists in every subgroup of the population. It doesn't matter whether you do studies on children, whether you look at middle-aged adults, or whether you look at geriatric patients. The results are consistently the same, that people who are active and fit live longer, healthier, better lives. And I believe, and many other experts agree, that physical inactivity is the major public health problem of our time. We tend to just focus on the obesity message, and we also tend to ignore the physical activity problem, and I think it makes much more sense for us to go after that in a big way. Now, it's not just me saying that. The journal Lancet ran an entire issue of their journal of the summer before last on the global problem of physical inactivity. And every article in there had to do with the health risks and effects of an inactive and unfit way of life. And the concluding statement of this series of articles in the journal Lancet was that in view of the prevalence, global reach, and health effect of physical inactivity, the issue should be appropriately described as pandemic, with far-reaching health, economic, environmental, and social consequences. So really, how much stronger a statement could a journal as prestigious as the Lancet make regarding a health condition and it not get more attention? This generated barely a ripple around the world of concern, despite the fact that this journal had identified a pandemic with all these kind of implications. It really just does not make sense that we ignore this. And certainly when it's published in a journal that I rely on as a family physician day in and day out to make treatment decisions about my patients, could you imagine if they had published a series of articles on an infectious disease or some other type of health condition? We would have been all over this, but this barely generated any interest. Now, beyond some of the most prestigious medical journals in the world, in fact, our Surgeon General just last summer, speaking at the ACSM annual meeting, said that physical inactivity is the major public health issue in this country. So we've got the leading physician in the United States, the highest ranking physician at the time, one of the most prestigious medical journals, yet we can't seem to make any inroads in trying to use physical activity, exercise, as a medication. Now, I want you to just think for a minute if physical activity or exercise were listed in the physician's desk reference. And I think we all know the PDR, which is the largest compendium of medications that exist. In fact, it lists every drug available to me as a physician to prescribe to my patients to both prevent and treat chronic disease. Now, there isn't an entry for exercise, but imagine if exercise were a medication that were listed in the PDR. Think for a minute how it would look when you looked into the physician's desk reference. Well, the generic name for this drug called exercise would be physical activity. But we know it would come in a variety of other equally effective brand names, including walking, jogging, hiking, rolling if you were in a wheelchair. Some of the formulations of this drug called exercise would require specialized equipment to consume, and this would include swimming, aerobics, biking. Some of the formulations could be done in groups as team sports, including tennis, basketball, soccer, and some of the formulations we do just simply for relaxation and enjoyment, including dancing and gardening. But what's important to understand, all of these brand name formulations of the drug called exercise work equally well. We know the optimal dosage. It's around 150 minutes per week in adults, 60 minutes per day in children, has got proven efficacy. We have multiple studies to back up the benefit, much more than any other pharmaceutical listed in this PDR. We also know that even at low doses, this drug called exercise has a dramatic benefit. And for that reason, we advise patients to start off at a low dose and gradually advance it as tolerated. But it's important to understand that even minimal low dosages have significant effect on health and longevity. This is a drug that's completely safe in pregnant and lactating mothers. In terms of the indications and usage of a drug called exercise, I couldn't even begin to put them on one slide, but some of the highlights of the primary indications and uses for this drug, including, as I mentioned in the introduction, helping to prevent obesity, but more importantly, for mitigating the harmful health effects of obesity. It's a powerful drug in reducing the development and improving the management of diabetes. It can also prevent and treat heart disease. It lowers the risks of virtually all cancers, but our data is strongest on breast and colon cancer. Without a doubt, people who take this drug are much more likely to develop these cancers, and when they do develop them, they live longer and are less likely to die prematurely from them. It's an effective medication for the treatment of high blood pressure. It'll prevent osteoporosis, but more importantly, it can prevent the fractures much better than any medication we currently know, prevent the fractures associated with osteoporosis. It has a powerful effect in the brain. It can help us to manage depression and anxiety and reduce the risk of Alzheimer's disease better than any medication that we have. This is also the only recreational drug that I recommend to my patients. And the bottom line and most important thing is those who take it are less likely to die prematurely. Now, we know the dose-response curve for this drug called exercise, and it's very interesting and important for patients to understand that patients who are sedentary, who aren't taking any of this drug, who begin taking moderate amounts of this drug, get significant benefit. Now, to be sure, if you go from taking moderate amounts of this drug to higher amounts of this drug, you get some more benefit, but the curve starts to flatten out. The real bang for the buck is getting that person who's completely sedentary to take just taking moderate amounts of this drug. Now, like any medication, this drug is not without its side effects, and almost immediately when you begin taking this drug, you will notice a decrease in your blood pressure, pulse, and blood sugar. You'll notice that your muscles and bones will grow stronger. As I mentioned, you may experience a little bit of weight loss. You'll also notice significant improvements in your mood, confidence, self-esteem, and concentration. Your bowel and sleep habits get better. You actually look and feel better when you're taking this drug called exercise. And I think most of us who see patients on a regular basis can tell right off our patients who are addicted or taking this drug. Now, there are some more adverse reactions, to be sure. When you begin taking this drug in large quantities, particularly if you're not used to taking it, you may notice some sweating. There is the risk of over-injury, and it often happens when you begin taking too much of this drug too fast, too soon. You may experience what we call an overuse injury, but that can help be prevented by gradually taking a low dose and gradually increasing the dosage. There is, to be sure, an increased risk of sudden death while taking this exercise. It's very rare that it can occur, but you can see people who die suddenly while taking it. But what's interesting is the people who are most likely to die taking this drug are the ones who are naive to it, who are not taking any of the drug and then suddenly go out and consume a large dosage of the drug, such as when they go out and shovel snow in the middle of winter when they're not used to it, or have to run suddenly to catch a bus when they're not used to running, and then they're much more likely to experience sudden death. And what we find is those who take this drug daily, on a daily basis, dramatically reduce the risk of sudden death from all causes, and throughout the entirety of the day, while those who don't take it, if they do take a little bit of it, can have a high risk for sudden death. In terms of administration, it can be administered alone or with others. As I mentioned, it's best to start off slowly at minutes and intensity as needed. And I recommend to my patients they change formulations of this drug. There isn't one single formulation that works better than others. They can consume this drug indoors or outdoors any time of the day, and it works great in taking it in groups. So I think you'd have to agree if you found the drug in the physician's desk reference that had this kind of entry, you would certainly, as a physician, prescribe it to every patient. And as a patient, you would demand access to have such a wonder drug. Could you imagine if the big pharma companies had a drug like this, what they could do in terms of advertising? A drug that could prevent and treat chronic disease, and those who took it live longer. Surely every physician would prescribe it, every patient would want to take it, and the healthcare systems around the world would no doubt pay whatever cost the pharmaceutical company demanded for a drug that was even half as powerful. Now, beyond all these health benefits of exercise, I want to talk for a minute about the effect of exercise on quality of life. And a good way to look at one's quality of life is by assessing their functional capacity. That is the abilities to do the things you want to do each day. And if you plot a person's functional capacity with their age, you get something we call the geriatric curve. Now, here's the geriatric curve of somebody who follows a high-risk lifestyle, who's inactive, who smokes, who eats a poor diet. What you see is that at a relatively early age, they begin to notice a decrement in their functional capacity. And typically, this is as the onset of chronic disease begins to set in. It impairs functional capacity and impairs their ability to do the things that they want to do. And what we see is that at a relatively young age, people who follow a high-risk lifestyle enter into a stage that we would call deficient survival. These are folks who are alive but not really living. And for the most part, those who occupy our nursing homes, who go on disability, who cost us a lot in healthcare expenditures to care for, by and large, are people who have followed a high-risk lifestyle. Now, contrast the geriatric curve of somebody who has followed a high-risk lifestyle with a person who has followed a low-risk lifestyle, who's been active active, who doesn't smoke, you see a squaring off of the geriatric curve. Now, while that person who is a regular exerciser and a non-smoker may only live 7 to 8 years longer, the real telling part of this is that their quality of life is so much higher because they maintain that high functional capacity almost right up until the end. So I love the idea that we all want to die young. The goal is just to do it as late as possible. And in my mind, that's what regular exercise helps my patients to achieve. Now, beyond that, I think we've got some significant motivations in terms of healthcare systems around the country for promoting physical activity, because we know that active persons cost about a third less to care for. In fact, around in healthy, relatively otherwise healthy people, about $1,500 a year less. And I certainly believe that when you look at the sickest patients, particularly those with end-stage diseases, if we can get them a little active, there can be a dramatic shift in healthcare costs associated with caring for these folks. So what can be done? Well, that's why I'm speaking to you here today. I think that we need a worldwide exercise initiative. Every patient, every visit, every treatment plan, I think physical activity should be recorded as a vital sign. Every patient should have their exercise habits assessed, and patients should be advised of the physical activity guidelines, which recommend that they do 30 minutes of moderate exercise on 5 or more days each week. And this message should be the same from every healthcare provider. I don't care what your specialty, as long as you're taking care of patients, from the family physician to the obstetrician to the rheumatologist to the physical therapist, nurses, on and on and on. If you're interacting with patients, this is a free medication that anybody can prescribe, and you ought to be recommending this as the first-line treatment for most any condition that bothers a patient that they're dealing with. And I would challenge you to find me any significant chronic disease that isn't helped by exercise. And for that reason, I think we need to merge the fitness industry with the healthcare industry. You know, why can I, as a family physician, refer my obese patient to a bariatric surgeon, and our insurance pays for us to staple that her stomach, but I can't refer my diabetic patient to a fitness professional to help them get their sugar down more by eating right and more importantly, exercising? That just doesn't make sense that we have such a disconnect. Certainly, I am able to get a nutritionist to talk to that diabetic patient about their physical activity. When exercise is proven to be equally effective in managing diabetes, why can't I have a fitness professional on the healthcare team? It just doesn't make any sense. So that's been the goal of this Exercise is Medicine initiative, to make physical activity assessment and exercise prescription a standard part of the disease prevention and treatment paradigm for all patients. Now, this initiative was launched in November of 2007 in Washington, D.C. It's become a global initiative that's been sponsored by the American College of Sports Medicine and the American Medical Association. You can see in the upper picture Dr. Ron Davis, who at the time when we launched this initiative was the incoming president of the American Medical Association. And the first thing I did when I was elected president of ACSM back in 2007 was to meet with Ron, and we agreed that we would partner on launching this initiative. In addition, at that launch, we were joined in the bottom photo by our then Surgeon General, Dr. Stephen Galson, and the upper left photo is Jake Steinfeld, who was chair of the California Governor's Council on Physical Fitness and Sports, and Melissa Johnson, the woman in the upper photo, who was then the executive director of the President's Council on Physical Fitness and Sports. So we had a national launch of this initiative in Washington, D.C. in November of 2007, followed by, in May 2008, a global launch because there was such significant interest around the world in what we were doing. Our next Surgeon General, Dr. Regina Benjamin, actually became the honorary spokesperson for Exercise is Medicine, and we've enjoyed a close relationship with the Surgeon General's office supporting this initiative. We have a great website that I encourage you to take a look at, exerciseismedicine.org, with lots of content on there that can be useful for any type of healthcare provider. And as I mentioned, we've spread this initiative around the world because the physical activity guidelines in the United States are the same as they are in Brazil. They're the same as they are in Turkey. And it's just amazing to have a major public health issue that everybody around the world agrees on. And that has led us to spread this to 40 countries and 7 regional centers, actually well over 40 countries, all of us saying the same thing, that physicians should assess the exercise habits of their patients and make a proper exercise prescription. And you can see this map of countries where this initiative is spread. It's been very easy to spread because everybody agrees with the idea. It's a very simple message and one that we just need to see take hold. Now, as I mentioned, one of the essential first steps in implementing this exercise as medicine idea is to think of exercise as a vital sign that's inputted into every healthcare record. And it's essential in moving this idea forward that we include it in electronic medical records. And we've pioneered this at Kaiser Permanente, where I've practiced my entire career. We began using an exercise vital sign in our Southern California medical office in October of 2009. Now, since that time, we've spread its use to all 35 of our medical centers across the country, in which care for over 10 million patients. And in our system, the medical assistants ask and record the exercise vital sign at every visit, and it doesn't matter what specialty you're seeing. We do this in primary care as well as all specialty care, and even, in fact, with our physical therapists and other nursing, clinical nursing, and physical physician's assistants. Now, this is what our electronic medical record looks like. We use the EPIC electronic medical record, and you can see the tabs of the chart listed on the left, and on the right under charting is the visit navigator, and right underneath traditional vital signs are what we call exercise vital signs. And the way this is used is that the medical assistant, as they're rooming the patient and they're measuring the traditional vital signs, the blood pressure, pulse, temperature, so on, along with recording the patient's weight and height so we can measure BMI and whether or not they smoke, the patient is asked two questions about their exercise habits. The first question is, on average, how many days a week do you do moderate to strenuous exercise like a brisk walk? The medical assistant then clicks 0 through 7 based on the patient's response. The follow-on question is, on those days, how many minutes do you exercise at this level? They then click 10, 20, 30, 40, and so on. The computer then multiplies those two responses to give minutes per week of self-reported exercise. And we're looking for adults to be doing 150 minutes or more moderate exercise. And if they're not, they're flagged with what we call a best practice alert, which simply reminds the clinician to counsel that patient on exercise. Well, what do we ask our physicians to do about it? Well, if you're running late, you've got 10 other things that day that you have to deal with, we tell them to relax. Don't worry. If you missed it this time, you can talk about it the next visit. At least the medical assistant has asked the patient. But what we ask is, if you have just 1 minute, if you've got 30 seconds to at least make a single statement, either say, hey, good job, I see you're doing 150 minutes a week of exercise, keep it up, or today I noticed that your blood pressure is high and you report you're not doing any exercise. Before I start you on a medication, before I start you on insulin for your diabetes, or I add a medication to help control that blood pressure, why don't we try having you walk 30 minutes 5 days a week and follow this up and see if we can't control it simply by getting you walking. And in fact, in my office, I have these little tear-off sheets that just have a pre-prescribed walking prescription to get patients walking 30 minutes a day, 5 or more days a week. And if that doesn't work, then we'll go to medication. I'm certainly not implying that we don't use medication, but this has to be the first-line medication. We have just too much evidence supporting that. Now, if the physician has a couple of minutes, we encourage them to review key messages about the importance of physical activity, to offer them a generic exercise prescription, walking 30 minutes, 5 days a week, or cycling, or jogging, or whatever it is that patient likes. We also have lots of resources, and in our system, we have a health store right here at my offices that I can send them down to get a pedometer. We've got DVDs with all kinds of exercises, from chair exercises for elderly patients to regular aerobics programs and things like that are on DVD. We've got all kinds of resources in communities, from YMCAs to fitness professionals that I can refer patients to. So we have lots of things we can take advantage, and we use in our system health coaches that will call the patient and work with them, mail them a pedometer, and work with them on getting more active. Now, if you've got 5 minutes for more brief counseling, although I don't think I've ever met a healthcare provider who said, I got 5 extra minutes, I'm happy to try something different. But if they do, it would be great to assess readiness for change in each of your patients, or really explore in detail what are the barriers that are preventing them from getting more exercise. But, I think this gets a little excessive to expect the healthcare provider to add this onto already busy schedules. And for that reason, I think we need to add in some other things, and I'll talk about in a minute. And one of the first things we started was this Everybody Walk campaign. It was started by our chairman and CEO, George Halverson. And George looked at the data on this and really believed that the single best thing that healthcare systems could do to improve health was to get America walking. And so that's what this campaign has been. And I'd encourage you to take a look at this website, everybodywalk.org. It's full of great content that you can use, you can refer patients or clients to that can help them get more active. And on this website, we have an app that you can download on a smartphone. We've got all kinds of content that's constantly updated on some of the latest studies and motivational videos to encourage patients to exercise. So I think it's an excellent resource for healthcare professionals to use. But I really think that clinicians need help in clinic. We need to move beyond simply telling them to go walk. I mean, that's great, and it's my first line default exercise prescription. But there is so much more that can be done with exercise and physical activity beyond just cardiovascular fitness. We should be taking advantage of the benefits of strength training. It has a dramatic effect on slowing the loss of lean muscle mass that occurs as we age. It can help build bone density, and we tend to just put our focus entirely on medications. We're driven by pharma to prescribe these pills to improve bone density when, in fact, doing a resistance training program would be better. And these pills do nothing for sarcopenia, the loss of lean muscle mass that occurs as we age. That has a dramatic effect not only on quality of life, but the risk of falls. In addition, we know that as we age, we lose flexibility, and it's very important to do regular flexibility exercises to maintain and improve fitness, particularly as we age. And again, this is another thing that can help prevent falls. We need to be able to focus on those. And to do that, I think I need to be able to refer my patient perhaps to a health club and a fitness professional there. And we've been trying to promote this with what we call the Exercises Medicine Solution, because much of the ACSM membership is fitness professionals. And so we call on healthcare providers to make that physical activity vital sign, to issue an exercise prescription, oftentimes just walking, and so they can do it in alone or in group activities, or even referring patients to park prescriptions. Those are all great self-directed physical activity programs. But I think we need more than that. And if patients need more, I think we ought to be able to refer them to a fitness person in a qualified setting that can help my patient get more active. And so we've been trying to connect this fitness world with the healthcare world, and that's really the next step. So I think the future challenge is to make that happen. We need, I think, to change the role of health clubs, to place that emphasis not so much on clubs, but on health. How do we get more clubs interested in targeting populations that need their service? We really, I think, need to get them to reach out to a new demographic, and that, in fact, may be reimbursing it for us. I think this would be better money spent than most of the money we spend on these darn pills and procedures that we are so enamored with. And associated with that, we need to try to look at the role of the fitness professional to help us merge fitness with healthcare. We need to get fitness professionals, personal trainers, to think more about hearts and lungs than they do abs and buns, to think more of their patients as not as clients, but as patients that need their help. And I think it would be much more satisfying them for them to say, I actually today helped a patient prevent diabetes, than it is getting to look better in their swimsuit. How do we engage fitness professionals to move forward with this idea and support exercise as medicine? We're also working hard on campuses. I've just been dismayed at the way physical activity has left the schools. You know, it's interesting, over the past 10 or 15 years, we had tons of these trying to do good folks who took the sugary beverages and the snacks out of vending machines, which was great. No one would argue with trying to get more healthy food in the schools. But at the same time, they were taking away Gatorade out of the school cafeterias. They were taking physical activity, and nobody seemed to notice. We just let that happen on our watch. And so we've started an exercises medicine on campus program, starting with our universities. We started at Chatham University in Pittsburgh, and Dr. Karina Winters chairs this exercises medicine on campus initiative to make sure that no student leaves the college and university without a lifetime plan for fitness. I think we've done a horrible job in our schools promoting physical activity and teaching our kids to be fit. And this, in fact, really it plays a big role in the current obesity and chronic disease epidemic that we see, is the fact that we've let physical activity out of our schools. We've also been using exercise in the hospital. It's a powerful tool, and in fact, I think exercise has the biggest effect in those who are the sickest. And we know that from multiple studies that if you are admitted to the hospital and you lie in bed all day, you're much more likely to suffer with a chronic disease. you're much more likely to suffer while in the hospital from that disease. In fact, you'll have longer lengths of stay and higher risks of complications. Everything from bed sores to pneumonia to urinary infections are much higher in people who just lie in bed while they're in the hospital. So we put a little activity monitor around the ankle of all of our patients, and we're measuring the steps they take, so that when the doctor comes in around in the morning, I know how many steps my patient has taken, and I can encourage them to get out of bed and start moving. So let me summarize that we have just got absolutely overwhelming evidence on the cost and health burden of being physically inactive. At the same time, we've got evidence to show us that the benefits of exercise and the prevention and treatment of chronic disease are absolutely irrefutable. And for that reason, I believe all healthcare providers have an obligation to inform their patients of the risks of being sedentary and to make an exercise prescription. And to do this, to support this, I think we really need to have the fitness industry with fitness professionals and health clubs. We need to get them to step up and play a key role in promoting physical activity to patients. I think we need to merge fitness with healthcare, because exercise is a medicine that all patients need to take, and I think all of us need to work to make that happen. So thank you very much for listening, and I hope that you'll become part of the big pharma movement to promote exercise, more exercise, less pills, less procedures. I think would do healthcare tremendous good. So thank you very much.
Thank you, Dr. Sallis. That's a very interesting presentation and extremely relevant. I appreciated your framing exercise as a drug with a position in the physician's desk reference. I think that's a great way to look at exercise, and sort of an interesting comment, aside maybe inadvertent comment, on how we view drugs, treatment, and how we should be viewing exercise as a treatment.
Well, thank you very much, Kristen. Hopefully that folks will take this to heart and integrate it into their work each day.
I agree. So if anyone has any questions about our presentation today, or for Dr. Sallis, you can email them to me at oaaction@unc.edu. Again, that's oaaction@unc.edu. And I will forward them to Dr. Sallis, and we will see what he has to say. Briefly, tune in for our September 16th webinar with Dr. Kelly Evenson. Dr. Evenson is a research professor in the Department of Epidemiology at the Gilling School of Global Public Health at University of North Carolina, Chapel Hill. Check out our website events page for more information on that upcoming webinar. Once again, thanks to you, Dr. Sallis, for a great webinar today.
Thank you.